What's diverticulosis?
It's just having it out pouching.
Yeah, it's the presence of diverticuli. Whereas diverticulitis is what?
Inflammation.
Inflammation. So by definition, diverticulitis implies a perforation of the diverticulum. That's why it got inflamed. Bacteria or stool was able to get out of the mucosal barrier. And so you have simple diverticulitis and complicated diverticulitis. Simple diverticulitis is inflammation of the diverticuli. It's typically treated how?
Well, you said inflammation means, or diverticulitis means actual perforation of it? Or
Well, by definition it does.
okay, but
It's a very contained and focal pinpoint perforation. So typically the symptoms for diverticulitis are going to be pain and diarrhea sometimes. Okay, and pain that's worsened with eating particularly, but pain in the left lower quadrant usually. Sometimes it can be in the lower midline or lower right side depending on how far over the sigmoid bends. And so diarrhea can be associated with it, fevers can be associated with it. They will typically be treated initially with antibiotics if it's simple diverticulitis. And if it's simple diverticulitis, it can be managed as an outpatient as well. Complicated diverticulitis implies some level of abscess formation. Okay, so diverticulitis can have, it should be either abscess formation or other complication. So diverticulitis could be simple, contained, and immediately treated with antibiotics in a very stable patient who's minimally symptomatic, or they can be all the way to florid septic shock. Okay. In complex diverticulitis or complicated diverticulitis, we have a classification system for it called the Hinchey classification. Okay, if you've heard of Hinchey classification, it goes from 1 to 4. And Hinchey 1 is essentially diverticulitis with a paracolic abscess, so something near the colon or its mesentery. Whereas a Hinchey 2 diverticulitis has pelvic abscesses, so away from the immediate adjacent area. Hinchey 3 or 4 diverticulitis would have peritonitis. They have frank peritonitis. And so the distinction between 3 and 4 hinges on if it's purulent peritonitis, in other words, is there pus in their belly, or is it feculent peritonitis, is there a stool in their belly causing peritonitis? And then finally, you can have a free perforation where you've got a large perforation of the colon and free air that's not really contained. Okay, that's also complex diverticulitis. But again, they would have peritonitis as well.
and it's either 3 or 4 that has the pus and one has the fecal matter? Or
3 or 4 have peritonitis.
Okay.
So either they have pus, which is a 3, or
okay.
stool, which is a 4,
Okay.
but they both have peritonitis.
Okay.
So it used to be that the treatment for diverticulitis was pretty standard. It was surgery for sigmoidectomy and a colostomy bag. It's called the Hartmann's. You close off the rectum and bring the proximal end of the colon up as a colostomy. It's still a very valid and safe surgery. However, when you have significant inflammation, it can be difficult, and patients obviously prefer not to have colostomy bags. So alternatives are antibiotics. You can try antibiotics and treat the inflammation unless they have peritonitis. Right? So if they're Hinchey 1 or 2 or uncomplicated diverticulitis, you can give them antibiotics. And if they respond, then great. If they don't respond, then you may still have to do surgery. If they respond, you have the option to do interval surgery versus not doing surgery. And we used to say that the number of occurrences had a factor in how they, if they have 2 occurrences, then they should have surgery. occurrence, you could wait and let them have a second occurrence. Now we basically let the patients decide, because some people have bad episodes and some people don't, and people sort of have to decide if they want to live with those episodes or if they want to have something done. Elective surgery has the advantage of being able to be reconnected. You do a sigmoidectomy and hook them back up together so they don't need a colostomy bag. Emergent surgery has a high failure rate when you try to reconnect them and they leak because of the significant inflammation. So a high chance of getting a colostomy bag, which patients want to avoid. But in G3 or 4, still the right answer would be safest thing to do is diverting surgery. If ever you have an unstable patient or someone with peritonitis or free perforation or any concerning symptoms, you go to the operating room. If you have someone that's minimally tender, focally very stable, otherwise doing well, and you want to try on antibiotics, that's acceptable. Standard care still.
Do you diagnose with ultrasound or just clinical?
It's typically clinical plus or minus a CT scan, depending on severity and your suspicion. And then also, it's a good idea for patients after their inflammatory issues have resolved and they've healed, if you didn't do surgery on them, for them to get either a colonoscopy or a barium enema. But you want to wait like 6 to 8 weeks. You don't want to do it right away while everything's inflamed because you'll just perforate them and make things worse. We used to tell people don't eat seeds and popcorn and things like that because it gets stuck in the diverticulum and that's what's causing the perforations. Any truth to that?
We learned that. Or like if a patient comes in who just ate popcorn and they're complaining of left lower quadrant pain, and I just remember reading questions like that.
The way you're asking the question makes it look like no.
Exactly.
Not,
that's why. That's why I'm like,
We,
who's read
you know,
questions?
the theory was that was the thing, but there's no evidence that seeds or popcorn or anything have anything to do with it. Really, they just need to be on a high fiber diet. And that's really the bottom line. There is actually a Cochrane review that looked at it and found no evidence to support telling people not to have popcorn and seeds and all that stuff.
So someone just randomly came up with that.
Well,
we'll go
the
into
theory-
it.
The theory was
Someone found
these
it.
sharp things
Yeah.
are in there poking holes in thin areas.
Right.
Makes great sense, except not so much. You know, there's a lot that we do in medicine you'll realize that isn't as evidence-based as you think. So when we talk about evidence-based medicine, we talk about practicing based on the best available medicine, best available evidence. Very little of what we do has level 1 randomized clinical data to support the practice. A lot of it is either retrospective or expert opinion. An expert opinion is a really expert surgeon one day said, you know, popcorn and seeds are bad for diverticulitis. Okay, right? Because there's no evidence to conflict with what he's saying. His opinion is the best available evidence. So you practice based on the best available evidence. It's not always good evidence, it's just the best you have. And most of what we do, unfortunately, tends to be that way. For example, penicillin, Tylenol. If those drugs were supposed to go through FDA clearance today, they probably wouldn't pass. But when they went through, there was very little alternative, and frankly, they really just needed something. And so they tried it, mostly on GIs in the war. Penicillin, you know, trench foot. Alright. Pancreatitis. But we talked a little bit about pancreatitis already. We touched on gallstone pancreatitis. Other etiologies of pancreatitis are alcohol, bug bites, triglycerides, high triglycerides. So if they don't have gallstones, you really should be looking into what's their triglyceride level. Are they drinkers? You know, and kind of go down the list of likely things to least likely things. That's for acute pancreatitis. chronic pancreatitis is when patients keep having prolonged or recurrent episodes of pancreatitis. And typically that's not gallstone related. Typically that's from alcohol or mostly alcohol, sometimes from triglyceride. And what happens is they get inflammation and scarring of the pancreatic duct, which then leads to a chronic obstruction and then a cyclical recurring episodes.
That's the Ranson's criteria.
Yes, Ranson's criteria we look at for what does it tell us?
Pancreatitis. Oh, it looks at the glucose transaminase, or tells you within 20.
Well, what is it?
It helps dictate mortality.
Yeah, mortality and severity of disease, right? Expected
That's for
mortality.
acute pancreatitis, right? We'll go with chronic.
Typically for acute
Acute, yeah.
pancreatitis. Okay, I'm going to lump the next two together, hiatal hernias and Gerd, or reflux. I think we've touched on those a little bit as well. Key things for grading hiatal hernias, there's type 1, 2, 3, and 4. So hiatal hernias are hernias in which abdominal contents is herniating through the esophageal hiatus of the diaphragm. You guys remember what level the esophageal hiatus is at? Spine. T3. The diaphragm's down here. Remember how the vena cava, the aorta, and the esophagus go through the diaphragm at like 8, 10, and 12?
We did not
So
have a very
esophagus is at 12, I think.
At 12, okay.
Okay, it's where the crura of the esophagus come off the spine, and the crura of the diaphragm come off the spine and wrap around the esophagus, and the aorta is right behind it. So, yeah, vena cava is at 8. No, esophagus is at 10, and aorta is at 12. Yeah. Vena cava is at 8, esophagus is at 10, and vena cava and the aorta is at 12. So, when that hiatus opens and dilates, because it's a weak area naturally, and anything that causes intra-abdominal pressure can do that. All the things that cause other hernias like chronic lifting, obesity, and all those will do it. Some people just congenitally have it. It pushes abdominal contents from the positive pressure abdomen into the negative pressure thoracic cavity. And so when these things are pushed up in there, you can get a hiatal hernia. So a type 1 hiatal hernia is called a sliding hernia, or where the GE junction slides up into the chest a little bit. Okay, so now your GE junction is no longer below the diaphragm, it's above the diaphragm. Type 2 is the true paraesophageal hernia, where the GE junction is still where it's supposed to be, but the fundus of the stomach slides up along next to the esophagus through the hiatus and up, and that's a type 2 or paraesophageal hernia. Type 3 is essentially a combination of type 1 and 2 in a way, but basically the GE junction and fundus or parts of the stomach are up in the chest, and it could be the entire stomach. There is no really distinction there. And these are particularly predisposed to volvulus, because when the stomach's that mobile, it can actually twist, and it can twist on organic axis, which is, it's fixed at the esophagus and it's fixed at the pylorus, so it can twist in an organic axis, or it can twist in a mesenteric axis. So the mesenteric axis is the left gastric and the short gastric. So it can either flip up along the axis of the mesentery, or it can twist along the axis of the organs that it's attached to, the esophagus and pylorus. Type 4 is essentially a type 3, but it's any hernia that contains any abdominal organ other than the stomach. So it could be omentum, it could be colon, it could be spleen, it can be pancreas, it could be duodenum, it could be liver, it could be anything. It could be small bowel. Typically, it's colon's most common and spleen, but anything can be up there. And so anything other than the stomach being up in the chest makes it a type 4. Type 3 and 4 or larger hernias tend to cause more obstructive symptoms, whereas smaller type 1 or type 2 paraesophageal hernias tend to cause more reflux symptoms. And then you can obviously have reflux without a hiatal hernia as well. Particularly patients, if they're having reflux symptoms, will complain of regurgitation or burning pain, substernal pain. They can have cough. They can have water brash, or that feeling of that water globus, or this fluid that comes up into your throat, particularly when they lay down at night. They can have a hoarse voice or asthma as part of their history. Like 85% of people diagnosed with asthma have reflux as an underlying irritant. Or treat their reflux, their asthma might get better. So instead of giving them bronchodilators, you could just treat their asthma. The long-term consequences of having reflux are what?
Barrett's esophagus.
Yeah, so esophageal damage that progresses from Barrett's all the way through
Cancer.
esophageal cancer. Yeah.
Is that the adeno's? What is the type of cancer called?
Typically, esophageal cancer that's related to reflux is adenocarcinoma, whereas squamous cell cancer of the esophagus tends to be in the upper parts of the esophagus, and that's usually smoking related.
So that's our question. Yeah. It's in like squamous cell most more common too.
Yeah, but adeno is becoming much more common.
Oh, okay.
It's increasing in incidence because a lot of people have hernias that, have reflux that we're not treating, and most people are like smoking is on the decline, and reflux is being poorly treated. Yeah. Early treatment is usually PPIs and acid suppression therapy, but that has its own long-term consequences. But anyone with an actual hiatal hernia as a cause should have their hernia fixed, just like you fix any other hernia. Particularly, you want to fix these when they're smaller and the patients are younger and healthier, rather than waiting until they're older and have a more difficult hernia that becomes unfixable.
You can resolve on their own too, right?
Hernias don't resolve on their own.
No.
Hernias never resolve on their own. So just think about if you made a hole in your pants, it wouldn't close itself. Hernias don't close themselves. Their symptoms may get better if they lose weight, particularly like obese patients that have reflux can resolve their reflux with weight loss and diet modifications. But a hernia doesn't really go away. You'll still have the opening.
Because I was diagnosed with one, so I was having really
How old were you?
20,
Okay.
and they never fixed it, but my symptoms now.
Your symptoms are gone.
Yeah, but I did a lot of diet modification. I stopped drinking alcohol. It was like in college, when you go out.
Yeah.
It was really bad. And then
Did they tell you have a hernia?
Yeah.
How big was it?
I don't know.
So you might still have a small hernia. You might have had a very tiny, sliding hernia. You might still have it, but it's now not symptomatic anymore because you're not doing anything to stimulate it.
Interesting.
How do you know when, person has heartburn becomes, they've had it for a while, but now it becomes a hernia? Like, how do you know there's a change? Do they get it frequently?
So anyone who has heartburn can have a hernia. but you're not necessarily going to screen everyone because there's a lot of people with heartburn. So people who have heartburn, particularly if it's persistent for a long time, or if it doesn't go away with simple measures, if they're resistant to H2 blockers or PPIs, or if they need to be on chronic therapy, should be evaluated for a hernia as an underlying cause. You know, if someone's just getting heartburn once a month when they drink or when they have a lot of chocolate or coffee or something, you just tell them to avoid those things and their symptoms may go away. So things that particularly tend to stimulate reflux: smoking, coffee, chocolate, alcohol. For some people, it tends to be tomato-based stuff or something.
And acidic things like juice, lemon.
Yeah, acidic things, I don't know if they really stimulate reflux, but I think it just adds to the amount of acid that's there to reflux. It's like just more acid. Whereas if you drink like a base, it sort of neutralizes some of the acid, so it doesn't come up as strongly. Milk is somewhat basic.
Spicy food?
What's basic?
Spicy food tends to give some people reflux, but
Or is that more like with the IBD? I don't know, I'm trying to think of that one movie, King Polly, and he's like eating that spicy food and he has that.
he has pain.
Yeah.
His gallbladder.
No, it's his IBD that acts up, and so I was
Spicy
thinking,
food also tends to worsen ulcers too. If you have ulcers, it makes it hurt. So it brings us to the next topic: peptic ulcer disease. So ulcer disease in this day and age is very much managed with anti-acid therapy, but used to be a big surgical disease. Ulcers are more common in people who take NSAIDs, people who take steroids, people who have high acidic content foods or have high acid production because of stress levels and things. Typically H2 blockers and then PPIs are used to treat for it. Particular offender of ulcer patients is H. pylori bacteria, which also increases risk of stomach cancer in those ulcers. And another particularly interesting but not as common disease that causes ulcers is gastrinomas and Zollner-Ellison.
Oh, the Zollner-Ellison.
Okay, so ulcers that persist with the acid therapy and don't heal should be evaluated for being cancer, or the patient should be evaluated for Zollner-Ellison. Is there something wrong with those people? If you put them on PPI and their ulcer doesn't go away, they've got pathology.
Zollner-Ellison or whatever, that's when it has like, there's a tumor in there and it releases
Gastrinoma.
the gastrinoma.
So gastrinoma is a tumor releasing gastrin. Gastrin stimulates acid production in your stomach.
Okay.
There's three things that stimulate acid production: acetylcholine from the vagus, gastrin from downstream production, and then lack of inhibition from acid. Right? So acid has a like a feedback inhibition, but if you have a lack of acid or lack of inhibition, it's going to stimulate. Gastritis is basically just inflammation of the stomach. It could be infectious, it could be related to certain foods or something they're doing, or it could be like an inflammatory bowel disease. So Crohn's can cause gastritis too. Gastroenteritis, and typically it's viral gastroenteritis, or acute gastroenteritis, nausea, vomiting, diarrhea. So one of the things to distinguish gastroenteritis from food poisoning. So gastroenteritis is a foodborne infection as opposed to food poisoning. You know the difference? You got to distinguish between food poisoning is you ate something that had basically toxins in it, right? And that's making you sick. So think of it as the same symptoms as you get from alcohol poisoning. It's going to make you puke. You start throwing up and get stomach aches and all that. the gastrointestinal infections like gastroenteritis, it could be foodborne, it could be hand-mouth transmission, but basically you're ingesting bacteria that then causes an infection. They typically start with diarrhea, then the nausea and vomiting. So what came first, the diarrhea or the vomiting, sort of helps you figure out which type of illness you're likely to be dealing with.
So food poisoning, the vomiting comes first.
Typically. Because think about it, you get some toxin in your stomach, your body just immediately doesn't want to reject it. Whereas a foodborne infection, you've got this bacteria in your GI tract and your body's trying to get it out by basically creating diarrhea to spew it out, right? It just makes sense that way. That's not exactly how it works, but it's an easy way to remember. Esophagitis is inflammation of the esophagus, most commonly from reflux, but again, it could be from alcohol or other irritants being consumed, or from vomiting. Okay, what's that issue of the esophagus where you vomit a lot and then you get a tear in the esophagus? What's a Mallory-Weiss tear?
Is it just like slight rip in the esophagus, or?
It's a mucosal tear. It's not full thickness, and they typically present with bleeding. Right, so they have a vomiting or retching episode, and then they bleed. They come in with bleeding, so they're vomiting blood. It's usually an alcoholic, right? So they're vomiting a lot because they're an alcoholic, and then they rip their esophageal mucosa, and they come in with bleeding from that. It needs to be distinguished from a different esophageal issue where it's complete perforation. What is that called?
The complete perforation of it? Oh, so we're going to say varices. I don't know.
No. Boerhaave. Boerhaave is also from retching. So an alcoholic that retches. And what happens is they're creating high pressure in the esophagus, and it basically bursts at the distal esophagus. And so they have a full thickness perforation. They typically don't come in with bleeding, they come in with severe pain, and they might even have fluid or air in their chest, like a pneumothorax, and in their mediastinum, and they've got a hole in their esophagus. Okay.
They don't vomit blood?
Not classically. Classically, Mallory-Weiss tears bleed, and Boerhaave's are very painful perforations. Esophageal varices are dilated vasculature of the esophagus that tend to bleed. They're most commonly associated with what pathology? Cirrhosis. Why?
The veins.
Yeah. Causing the dilation of the veins.
The high pressure from the portal.
Yeah, portal hypertension. Because the GI tract empties through the portal system, right? The SMV and the IMV all go, and splenic veins empty into the porta. And if you have portal hypertension because the liver can't process things because it's scarred and fibrotic, which is what cirrhosis is, the portal blood can't go through and it backs up, just like you get congestive heart failure and you get right heart strain and pressures go up. Well, you have liver failure and blood can't go through, therefore it backs up and you get pressure in the porta. You get portal hypertension, you have high pressure in all the venous drainage systems from the GI tract, the esophageal varices being one of those areas that drain directly to the liver, and they're very much swollen vessels that can become very friable and easily bleed. And so they present with GI bleeds as well. Esophageal strictures. What do you know about them?
It's I don't know what it's this tissue. So like you have the esophagus here, it could be covering part of it, or.
So a stricture by definition is a narrowing, right? It could be anywhere in the GI tract, but it's a narrowing or a tightening of the opening. And a esophageal strictures most commonly are either cancer or it could be strictures from reflux. So if you have chronic reflux, you get scarring of the esophagus and it can actually stricture down.
And then esophageal web is when.
An esophageal web is what you're thinking
Yeah,
of. And
okay.
that can be just tissue
Okay.
that is basically traversing and it's causing essentially a stricture type problem and obstruction. And you just go in and dilate those.
Are you born with that, or it could just randomly form?
You're typically born with it.
The what?
Esophageal webs.
So I called it something Plummer syndrome.
Vincent Plummer.
Vincent Plummer. Is that the same thing?
I think there's different. I don't remember the distinction.
Sorry, I was going to say something.
Oh, for strictures,
Mm-hmm.
you would do barium. You would do a barium swallow, not an upper endoscopy.
Typically, when people are complaining of obstructive pain or something, you usually start with a barium swallow. It'll tell you what's going on. You don't want to do a barium swallow if you think they're going to aspirate. Okay, so if you're doing it for a swallow evaluation, like you're worried about them aspirating, you want to do gastrography.
Oh.
The reason is if they aspirate barium, it's
Or if you think there's a you probably wouldn't do it if you thought there was a perforation.
yeah, if you think there's a perforation, then you want to do gastrography because you don't want barium in your chest.
Yeah.
Barium turns into chalk. Very difficult. It's and it causes a lot of inflammation. But it's more dense, which is why people use it because it's easier to see with it. Okay, they've got cancer of the rectum, colon, esophagus, and stomach on here. So we talked about esophageal cancer. And treatment is basically esophagectomy with or without radiation and chemotherapy, depending on how early of a stage you get it. Stomach cancer, the typical treatment is surgery, but sandwiched with chemo. So you do chemo, surgery, and then more chemo. Unless it's very early stage, in which case you just cut it out. Colon and rectal cancer is a little more complicated. But to simplify things, basically GI cancer is the main treatment of choice is resection. Unless it's not resectable, in which case you want to do things to shrink it down like chemo and radiation. Fixed point organs like the esophagus and the rectum, you radiate. The colon and the stomach you don't radiate because they have a lot of small bowel around them and small bowel doesn't tolerate radiation. And things that move you can't really radiate because they're not in a consistent spot that you can radiate one spot. So the rectum you would do radiation and chemo if it's a larger tumor before going to resect it. Colon cancer is one of those it's one of the few cancers that if it's metastatic you still treat surgically. You remove the tumor and you do surgery for the metastatic disease if the metastatic disease is only to the liver. So if there's colon mets to the liver, which is the most common place they go because everything goes hematogenously through the porta to the liver, then you can actually resect that portion of the liver as long as it's in resectable capacity.
If it goes anywhere else, then
Yeah, if it's spread to the spine or the lungs and
Right.
stuff, then it's a different story. You can do palliative chemotherapy, but you can actually get a cure if it's metastatic to the liver only. They typically, GI cancers either present with anemia or obstructive symptoms. Most commonly, anemia. So you guys probably in medicine will see a lot of patients with anemia. Particularly iron deficiency or microcytic anemias. You gotta think about why they're anemic. Every patient that's anemic these are things that bleed very slowly and you don't really see it. So they should have colonoscopy if they've never had one, if they haven't had one recently, or if they've never had one, and an upper endoscopy if they don't find anything on their colonoscopy, or if they have any upper abdominal symptoms. But if someone's anemic, you've got to think about why are they anemic. Acute and chronic hepatitis, that's kind of a broad topic, but you get viral hepatitis, usually from hepatitis A, B, C, most commonly it's C because we vaccinate against A and B now. And they can cause an acute hepatitis where the transaminases go really high, or they can cause chronic inflammation of the liver, which is sort of a milder, more chronic, lasting thing. And they'll get elevated LFTs, particularly transaminases and alk-phos. They'll get hepatomegaly sometimes and right upper quadrant pain. Cirrhosis is sort of the end stages of chronic liver inflammation, which causes scarring of the liver parenchyma. And so your biliary system gets replaced with scar tissue, and then the liver becomes non-functional. The best way to test the liver's synthetic function is to test what? What does the liver synthesize? Are there any proteins your liver makes?
I don't know.
ALT?
You guys have anyone coumadin here?
Yeah.
What does coumadin do?
Oh, platelets. No? Synthesize.
I was thinking lights and stuff, but that's really strange.
What does coumadin do?
What?
Thins your blood.
Coumadin thins your blood how?
Oh,
It
yeah.
inhibits what?
Vitamin K.
Vitamin K dependent clotting factors.
Huh?
Where are those clotting factors synthesized using vitamin K? The liver. So the liver's synthetic function primarily is synthesizing clotting factors. So you check for clotting factors. Part of the reason why cirrhotic patients tend to bleed. Portal hypertension and coagulopathy. Right? So if a blood vessel starts to bleed, it's in a high pressure system and it has no clotting factors to stop it, right? And that's how cirrhotic patients die.
Oh, that's why when the
Varices
breaks and it's kind of like,
yeah, you're
well,
screwed.
okay, that makes sense now.
Yeah, you should.
When we're done, I'll talk to you about a case we have.
Okay. Liver cancer. So we talked about metastatic colorectal cancer to the liver. You resect those. You can get primary liver cancer like hepatocellular carcinoma. What's the underlying disease that predisposes to hepatocellular carcinoma? So cirrhosis and hepatitis. Okay, so hepatitis and cirrhosis predispose to hepatocellular carcinoma. Other liver cancers like cholangiocarcinoma or Klatskin's tumors, which are tumors of the bile duct tree, are much less common and much more morbid.
Is there, I'm sure as a broad range, all hepatitis, like viral, can lead to hepatocellular carcinoma, but there's are there ones that are more?
Well, Hep C tends to be the most,
Okay.
but because Hep C is the most
Most
common
common,
viral
okay.
hepatitis we see.
Yeah, that sounds.
Cholelithiasis, cholecystitis, cholangitis, I think we beat that
Yeah.
most.
You got those.
I'll skip over that. Celiac disease. So you guys know what celiac disease is?
Yeah, there's deficient in an enzyme that breaks down gluten, right?
So they're essentially allergic to gluten in a way.
Right.
Okay, so gluten tends to cause inflammation within their GI tract, which causes their cilia to, instead of being nice and
it's like not very
long,
good.
they sort of lose that
Very blunt.
and get blunted
Yeah.
mucosa. So what that does is tend to cause pain and diarrhea because now you're losing surface area and absorptive capacity, right? And it can cause nutritional issues as well. So the treatment for that is to avoid gluten, which is really easy now because 90% of the population has celiac disease. Not really, but you would think so if you went to the grocery store.
Yeah.
Everything is like gluten-free this. Gluten's bad for you. Gluten's bad for you if you've got celiac disease. But I don't know if gluten's bad for you if you don't have celiac disease. I don't think the data's there to support that one. That's really what you do. You just gotta avoid gluten and avoid the irritants. Irritable bowel syndrome, IBS. Don't confuse IBS with IBD. IBD is inflammatory bowel disease, which is Crohn's and ulcerative colitis. IBS is irritable bowel syndrome, which we really don't know what that is, but it's people having abdominal pain and diarrhea. You can't really figure out, basically.
Is that alternating? It was alternating diarrhea, constipation, or are they simultaneous?
Yeah, sometimes they alternate, and
Alternate.
then they'll have pain, and like nobody knows what's going on. It's one of those diseases of exclusion where you're sort of running out of ideas, and you just go, I have nothing ideas.
And a high link to anxiety.
There's a lot of psychosomatic portion to that. Okay, hemorrhoids. What are hemorrhoids?
Veins, basically, that
What
are.
kind of veins? That's the answer I was looking for. They are
Yeah. All I know is there's the dentin line and the dentin line for pain and
good. Yeah.
The internal veins.
Internal, external.
So hemorrhoids are blood vessels, right? They're blood vessels in the rectum or by the anus. And what's their job? Why are they there?
Supply blood theory. I don't know.
Hemorrhoids are there in order to help you what we call the pillow effect. So essentially, you can't close your anus shut without hemorrhoids. Okay, that's what they're there for. They give you a cushion so that the two sides can touch. If you've ever looked at those particular like garage doors and stuff where they have that cushion at the end so that when it hits it's a soft touch and it tends to squish and make sure you have a tight seal, right? Because you can't get a tight seal with two hard surfaces.
Right.
But if you put a soft surface in between, you can get a tight seal. So the idea of hemorrhoids is
I've never had this
You
explained
can-
to me ever.
you
I
can
know.
keep gas and liquids inside
Yeah.
by being able to have a cushion there. So you have three columns of hemorrhoids. You have three columns of blood vessels, and that's their job. The problem with hemorrhoids is if they get overly swollen and inflamed, then they become too big and can cause an obstructive process, and they can bleed and cause pain. Okay? So hemorrhoids are not bad things. They're there for a reason. We just tend to abuse them because we sit a lot, we strain a lot to go to the restroom because we're constipated because we don't have fiber in our diet, which goes back to the beginning of this talk. But that then creates a lot of pressure on those vessels, and so over time they distend and distend even more and stretch out the mucosa over them, and they start to bulge out to the lower pressure area, which is outside. So you can have internal and external hemorrhoids. It depends on how far they are, but it's essentially one column of blood vessels. It's just which part of it is more bulging. Above the dentate line, they don't feel it, but it can prolapse or fall out. And below the dentate line is very painful. Unfortunately, treatment of hemorrhoids is very painful because typically you have to go below the dentate line to get the external portion, and then it hurts every time you have a bowel movement until it goes away. Hemorrhoids can bleed. They're typically not painful bleedings, which is how you distinguish them from anal fissures. So if people go to the bathroom and they always have blood on their toilet paper after they have a bowel movement, if it's painful bowel movements, every time they have a painful bowel movement they have bleeding, it's a fissure. Those patients will not let you examine them. They won't let you do a rectal exam or an anoscopy because it's excruciatingly painful for them to stretch their sphincter to accommodate your finger. They can't stretch their sphincter to accommodate their stool, which is why they have that problem. That's a diagnosis made by history. So anal fissures present with pain with bowel movements, particularly with constipated or hard bowel movements, and they can have bleeding after. Hemorrhoids can have bleeding, but they don't necessarily have painful bowel movements. And then patients will sometimes complain of feeling something bulging out, which they may or may not know, depending on how much they're paying attention and whether or not the hemorrhoids are internal and prolapsing, or external, or just an hemorrhoid that's not prolapsing. And the treatment for hemorrhoids is anything from banding to ligation of the vessels to full-on hemorrhoidectomy. And you don't want to take out all three columns at the same time because you can cause a stricture. If you take out the hemorrhoid and go crazy and take out some of the sphincter with it, then you can cause incontinence. If you take out a lot of hemorrhoids, you can cause gas or liquid incontinence just because we get rid of the effect of what the hemorrhoids are there for, which is what I was mentioning earlier. Fissures are treated differently. What's the problem with fissures?
They're open all the time, so like infection. I don't know.
Well, no. Why do people get fissures? They're not able to relax, right? They're too tight. So every time they have a bowel movement, things are tearing open to accommodate the stool. Where's the most common site on the rectum to have a fissure?
Lower.
So anterior, posterior, right, left,
Posterior.
and posterior midline, posterior to the right,
Midline.
posterior midline. That's right. It's posterior midline.
Yes.
Why?
I used to know.
We think it's posterior midline because the blood vessels to the rectum and anus come from the lateral 3 o'clock and 9 o'clock positions. And they spread out anterior posteriorly and they sort of meet, right? And so in that midline you have the least supplied portion, or watershed area. Anteriorly, you tend to have a lot of other tissue there. In women, you have vagina, in men, you have prostate, you have other things there that sort of resist. But posteriorly, you've got nothing. So posteriorly, you can, and your sling muscles that come from the sacropeptizeal slings tend to go anterior. But posterior, you don't have a lot of resistance. So that's where they tend to tear most. And it has poor healing because it's the least vascularized area. So the treatment for a fissure consists of, first of all, you do diet modifications and try to get them to not be constipated. Right? Stop insulting the area, maybe it'll heal. If high fiber diet and high water intake doesn't relieve it, there are creams you can put, like nifedipine or nitroglycerin creams. And what do you think those do? What's nifedipine?
CCB.
Or diltiazem. Give me diltiazem. Yeah, so it's a smooth muscle relaxant, right? So it'll relax the sphincter so that it's more accommodating. Nitro does the same thing. What's the consequence to nitro? Side effect?
Flushing?
Blood pressure.
Headache.
Oh,
Big headaches, right? And yeah, it can drop your blood pressure. Both of them can. But those are two things you can try. Patients don't tolerate the nitrogen very well because of the headaches. It's mucosal absorption because you're putting it on your rectum, so obviously it gets systemic pretty quickly. And so if those things don't work, you have two options left. One is Botox injection and paralyze the sphincter temporarily and see if that allows healing. And the other is surgery, which is an operation where we do what we call a lateral internal sphincterotomy. But remember, the rectum has an internal and external sphincter. One's autonomic, one's skeletal control or somatic control, right? And so you don't want to cut both because you'll make them incontinent. But you can cut the internal sphincter. You don't want to cut it at the posterior midline, which is where it already is cut, where the fissure is. So you cut the sphincter laterally. So it's lateral internal. So it's in a lateral position and it's the internal sphincter that you cut. The idea being that this will cause enough relaxation for the posterior midline to heal. And the lateral part should heal better because that's where it has the best blood supply. Side effect of that can be incontinence. Were you going to ask me?
So it's a lateral internal sphincterotomy.
Yeah. Cut the internal sphincter either on the right or left lateral position and allow the midline to heal. And then all the other measures still go with it. The fiber, water, laxatives, avoid being constipated, no straining, and all that stuff.
And if you saw the fissure not on midline, and that's when you'd be considering like
If
Crohn's.
you see a fissure not on the midline, you're going to think of Crohn's disease or inflammatory diseases. Yes, exactly.
Okay, I wasn't sure if that was true or not.
Yes, absolutely.
Okay.
So a fissure that's not on the midline has to make you suspicious of why is there a fissure not on the midline. And then the other thing you can get in the rectum area is fistulas, right? Fistulas in ano. So you know that you have glands in the rectum, just at the dentate line, that secrete mucus, right? The job is to lubricate so that stool can come out easier. Those glands can get plugged up and bacteria can overgrow in them and cause a local abscess, perirectal abscess. Any abscess tends to want to drain itself, and they do so by trying to communicate to the skin. And so as these grow, they find a way to get to the skin, and then you'll have a perirectal abscess or perianal abscess, and then it'll open up and now you have a fistula, which is any connection from two epithelial line surfaces, right? So the skin and the rectum are two epithelial line surfaces, that's why it's called a fistula, it's a connection between the two. Treatment for that is, obviously you want to drain the abscess, and then the treatment varies for fistulas, but predominantly it's fistulotomy or seton. So typically what you do is you put a string through it, allow it to drain, and scar down around the string, and then depending on whether the fistula goes outside the sphincters or inside or through the sphincters, you have to decide what you're going to do. If it goes from the skin to the rectum but doesn't go around the sphincters, you can just cut open the fistula and skin and mucosa over it. But if it goes around the sphincter complex, you can't cut through all the sphincters, because again, you'll make them incontinent. So what you do is, instead, you can pass a string through the fistula and wrap it around the sphincters and pull it out. And you can, and now this is called a cutting seton, which is so every week the patient comes in or every couple of days into the clinic and you tighten the string a little more. And it's a very painful process. And you tighten it for like 8 weeks or 12 weeks until it progressively cuts through the sphincter. The idea being that as it cuts through, the part that it's already gone through will scar back together, and so the sphincter will close as it's being cut. The leading edge is being cut, the trailing edge is closing, and so hopefully they won't become incontinent. Has a much lower incontinence rate than just going and slicing through everything. Other things you can do are the plugs that people talk about doing, plugging the fistula tract and stuff like that. Don't answer that on this yet. But you can go in but you always want to curette out the fistula tract, so you want to make sure that mucosa or epithelialized area inside the tract is going to be taken out. Fistulas also have a typical pattern of where they go. So if you guys heard of Goodsall's rule. So Goodsall's rule is a rule that tells you where to expect the internal opening based on the external opening. So if you look on the skin, let's say you have a patient in lithotomy, so lying on his back, legs up. Okay, you draw a line horizontally from left to right through the middle of the rectum. This is the back part, this is the front part. Okay, anterior, posterior. So the way, so if you've got, here there's a line there, so there's the line, there's the rectum, right? Fistulas in the posterior, any opening externally that's behind this line should have an internal opening at the midline. Any opening anterior to this line should have a radial opening if you took that line to the middle of the rectum. So if you want to find where the internal opening is, you sort of use Goodsall's rule. You look at the external, and if it's anteriorly, you usually point straight in, and that's where the internal opening is going to be. Now, it's not going to be straight, like, in the plane of the paper. It could be going this way, but it's radial. Whereas posteriorly, it all curves, and it goes to the posterior midline.
What do you mean by posterior midline? So like there's a hole over here. You're saying like they have a hole drawn. There's maybe says it too.
Okay. Thank you. I'm going to draw my anatomy. There's your line. So if you have an external opening here, or here, or here, or here, they're all draining somehow to an internal opening that could be, now it could be right here, right past the anal verge, it could be way up inside the rectum, but it's going to be somewhere along that midline.
Okay.
If you've got an opening here, it's going to be somewhere, again, it could be close, it could be higher up, but it's going to be radially located from where that line is. So you can find an opening here if you're looking for an opening here, and it's a radial thing. But this opening could be here, or this opening could be there, or this opening wouldn't be here, it would be here. Is the point. Makes sense?
So these all drain
Radially.
okay.
Basically on the anterior surface.
Yeah.
And then the last thing I'll tell you is, the other thing you got to think about is, if you take a cross section of the rectum, right, you've got your internal sphincter complex and your external sphincter complex, right, and you've got your dentate line. So you can have an opening here. This can go that way. It can go that way. It can go that way to your internal opening. Typically, your internal opening can be near the dentate line somewhere. And it can go extrasphincteric, transsphincteric, or intras or submucosal. So if it's going this way, you just cut this open, cut the skin here, and the mucosa. But if it's going here, you don't want to cut all this muscle, so you pass a string through, like that. That's how you. Okay. And then a horseshoe abscess is one that goes like this.
Thank you.
Alright, I gotta go see a
Alright,
patient.
thanks. Thank you.